Hello, everyone. Welcome to IFC webinar. I'm excited to see you all, and I see that the guests are still joining, and this is exciting. This is wonderful. So today we are going to talk again about infection control, and I wanted to remind you that all this year, this fiscal year, we are talking about infection control in various areas of the hospital, and actually that is for a reason. Because we are excited to inform you that we are launching our new module on infection control, and we will be talking about it later. It's a useful resource for learning. As Natasha already mentioned, we have numerous, but today let's focus on the infection control in specifically operating theater. Operating theater is a very important area in each hospital, and I think everyone would agree with this. From the point of view of the complex procedures that are performed there, from the point of view of potential risks, and from the point of view of infection control, of course. There are lots of specifics, specific processes, specific way of entering it, specific way of handling biomedical waste in it, specific ways of leaving it. For the staff and for the patients. Today we wanted to discuss whether layout plays a critical role in it, or it can be just any layout. Are there any best practices, global best practices regarding the layout of the operating theater? So I believe it's going to be an interesting discussion. I hope you will enjoy. And I'm happy to introduce the first speaker. That is Eric Wu, Regional Director of ECRI. And Eric will be talking about the processes in the operating theater related to infection control, and also some interesting statistics. Eric, over.
Thank you, Yulia. Thank you very much. And good morning, good afternoon, and good evening, wherever you guys are joining the webinar. And I'm really, really happy that you guys are here. This is a very important topic. Let me just share my screen. All right, we are ready. So my name is Eric Wu. I am working for ECRI. I'm based out of Asia Pacific office in Kuala Lumpur. Part of what we do as well relates a lot about the processes within the hospital and how we can make processes better so that patient safety can be upheld. That's really our mandate and our goal. When we work with ECRI in our region as well. So without more of introduction, I want to go straight into the topic that we want to talk about. I'm going to begin by talking about some statistics and information that are obvious. And ladies and gentlemen, they are obvious. And I just want to make sure I repeat this obvious information so you understand how important infection control is. And up to today, this century where technology is so advanced, we are so advanced, yet we are still concerned about infection that has been happening for centuries, right? So let's jump straight into some of the facts that we are going to be talking about more. Some obvious obvious information that I like to share begins with our hands. And 80% of the infection disease are transmitted by unclean hand. That's what statistics are telling us. So it's so important we talk about hand hygiene, and I think the world has talked about hand hygiene. I think down to school levels, we talk about hand hygiene. But still, we still need to talk about it because it's still a big problem based on the cases and the statistics that we read from all the reports that we see. So it is important to think about our hands, because our work really uses our hands a lot in hospital. So 80% of the infection are transmitted by unclean hands, right? Just imagine how many surfaces we touch every 30 minutes. And some regional universities actually did some studies, and they actually found that we touch on almost 300 surfaces every 30 minutes, and we're exposed to, this number is huge, 840,000 cells of germs every 30 minutes. So that's quite an alarming kind of statistic. So that's how dirty, I may say, if I may, our hands is and can be. So it is important really to understand the one of the key transmission of infection, or one of the key source of infection really is our hands, right? So more of some obvious information, and I'm sharing this slide and the coming slides because I think there is a lot of relevance with what we're talking about today. Although the hypothesis or the study they create or the analogy that they use are a little bit more commercial, but I think it's right. If you look at it, study done found that most of the germs spotted in the copier, for example, in the office. Nowadays, we don't use so much of a copier, but before internet was so good, before technology was so good, we use photocopy machine almost every other day. And if you can see the analogy that they use is 1.2 billion CFUs, colony forming units, on the button of the start and stop button in the copier compared to the toilet. So the toilet seat is actually cleaner compared to the buttons on the copier machine. So that was a comparative study that they did. So most studies, on average, desktop harbors 400 times more bacteria than an average toilet seat. So this one is very relevant because I think today, as we speak right now, we're sitting in front of our desktop. So we touches our desktop more than anything else. So you can tell that the surfaces that we touch, be it in the office or in our clinics or in our operating theaters, everywhere in our hospital today, we have computers. At least in my office, the desktop that I use commonly are touched by myself. Occasionally, someone else will touch it, but most of the time, it's myself. But in the hospital, that desktop that is sitting in the counter is touched by so many people. And you got to imagine the amount of germs that are actually being passed on into that desktop itself, right? Other analogies that you can look at is that people always think that the toilet is unclean, but actually, if you compare to a lot of other things, the toilet is actually cleaner. One of the things that my wife always say to me is that the dish sponges is extremely dirty, and true enough, study do show that they are very dirty, and comparatively to a toilet, they are much more dirtier than that. So this slides as well also tells us that the perception we have as to what is clean and not clean sometimes needs to be reviewed in that context. So if you look at other places like the gyms and all that, the studies have shown there's a lot of diseases that can be transmitted. MRSA is also transmitted through the gyms and why, right? So there are a lot of data that talk about that. London Metropolitan University tested on touch screens. I want to talk about this one because we have a lot of medical devices that are touch screen today. And they talk about the analogy of a restaurant, but I will relay this to the medical device we use in our hospital today. A lot of our medical devices are touchscreen. A lot of our computer screens are touchscreen. And these are areas where we sort of let the germs colonize, and that is actually one of the source of how bacteria or germs are being spread as well. And the last one, of course, is the shopping mall. So all these are just analogies to tell you it happens in our everyday environment, but it also if you take those everyday environment and put it into our workplace, you will see that there's a lot of similarities. Contaminated surface is not just in the public, in the toilet, in the gym, in everywhere else, but also in our hospital itself. The other part, other than surface touching and your hand, is the air. COVID has taught us a lot of lessons. We have learned a lot about it, and it's worse than any kind of air contamination or air transmittable disease we have ever experienced before. And we fully recognize that the transmission of disease through air is very real. And some of the statistics that are done, for example, studies that are done, if we are in a room, we are way much more at risk of contamination compared that in areas where they have open air. I think this is already a known thing because we learned a lot through COVID. So these are some statistics that talk about it. Now, I highlighted 2 points, the surface and the hand where we touch, the air transmission that is happening. And a lot of you are healthcare community colleagues, and I'm pretty sure you understand the details behind that as well. So I'm going to move forward to talk about really the operating theater that we want to talk about today. So operating theater is supposed to be one of our cleanest environment within the healthcare facility itself. And I said suppose, right? And why are we still concerned? Let's look at some of the data and facts that tells us why are we concerned about an environment or a facility that is supposed to be the cleanest in the hospital. So here are some facts and data. And ladies and gentlemen, bear in mind, these are based on data records that are reported. There are so many more that is underreported or non-reported. So we should take this with a pinch of salt. I strongly believe that the numbers are greater than what we see here on the screen. But these are the numbers that are reported thus far. So we will use this as a reference to think about. Report shows surgical site infection accounts for 14 to 17% of hospital-acquired infection. So it's not a small number. It's almost a fifth of all the infections that are acquired by patients in the hospital itself. So it is not a small number. Surgical site infection are hospitalized approximately 7 to 11 days longer. Therefore, and what's the implication? Meaning your hospital bed is lesser by 7 to 11 days because somebody is using it because they acquired an infection from your hospital because of surgery. So that's one key thing. The cost of caring for the patient has been extended to 7 to 11 days. For private settings, sometimes they charge the patient for it. For a public setting, then the cost comes from the public funds. And that increases the cost of caring for the patient. So this is a very, very important fact that I like everyone to share with our leaderships so that they are aware. This is not only about the patient's sickness, but this is also about the management of the hospital and also our facility itself. So if we have 17% delay, which means your bed is reduced by 17% all the time. So you got to really think about how we need to manage this and take this surgical site infection very seriously. Some data that is published, 2018 to 2020, they actually did a little bit of a study. They found 20,000 surgical site infections were reported out of a total of 1.2 million procedures in 13 EU countries. So they participated in the study, they collected the data. Out of 1.2 million surgeries, yes, the percentage doesn't look very alarming, but there's still 20,000 cases that are there, right? This is nice, the last factor here. When we did a sort of a study to look at what are the secondary review study, to look at what are the data published globally. So a study showed that they looked at 2,091 publications. They looked at 62 studies, 57 meta-analysis in 6 different locations with 488,594 patients. So this study that they looked at, the relevance was 11 out of 100 general surgical patients are likely to develop an infection 30 days after surgery. So according to all the publications and all the evidence presented, secondary review study shows that this is how 11%, it's very prominent. So 11% of your surgery is likely to end up having an infection. So that's the point I'd like you to hold, because I'm going to give you more statistics to tell you why we're talking about this topic and why IFC is asking me to talk about this topic today as well. Now, more statistics so that you can really think about. 2022, Statista has actually published an article. So they are saying that they have a record of 294 million surgical procedures worldwide. The estimated direct annual cost treating HAIs, this is all HAIs, not just surgical, right? Other HAIs as well. In the United States is 28.4 billion to 45 billion US dollars. This is how much it costs for different kind of infection. This table, if you go into AHRQ ARC, you will be able to see some of the values that is associated to some of the HAIs that is in the hospital itself. So if you look at just surgical side, because we're talking about operating theater today, if the prevalence is 11% of all surgery, and then if the case is 294 million, US dollar is 28,000 per patient, with referencing the data from the US. Hundreds of millions are now being spent just to deal with an infection that could have been prevented. Hundreds of millions of US dollars. The money is another point. You're talking about a number of patients. You're talking about a lot of patients. You're talking about 28 million or 280 million, sorry, patients. 280 million patients that are actually having problems after surgery. And that's not a small number to look at. So we got to really take surgical site infection seriously. Operating theater is supposed to be the cleanest room or facility in the entire hospital, but yet we are seeing all the challenges that comes with it, and the statistics talks about it quite clearly and evidently as well. So I did a lot more studies, and we found that some of the challenges or issues that leads to infection within the operating room. So I listed some of them here. To a lot of you who practices medicine or clinical work in the hospital, you may find this, yeah, but this is what we are doing. Ladies and gentlemen, if this is what we are all doing, we still have those statistics. So let's face it, right? I used to work in the hospital too, and I always tell I was an operating officer. So I always also tell people within my team members that if we're that good, then we won't have problem. So look at all this data, and these are published information. These conclusions are all derived from a lot of the study from adverse events that talk about the root cause to HAI or SSI from the operating theater itself. So inadequate sterilization, surgical instrument equipment surface in the operating room. I repeat, surfaces in the operating room are not properly sterile. They can definitely be the place where germs and bacteria harbors, and it's definitely the place where our hands that will be touching it will be carrying those things with us when we are caring for our patient itself. Hand hygiene. Everybody tells me globally, every country I go to I cover mostly Asia Pacific. Every country I go through in Asia, everybody tells me that I have very good practice in hand hygiene. I'm sure everyone in the room would tell me the same thing. But guys, let's look at the stats. The data don't lie. We still have problems with our hands. We're still not addressing the proper way of managing or cleaning our hands before surgery, after surgery, and while even during to a certain extent, and I'll talk about the glove in a while, but hand hygiene is still not the best of the practice. Because we still have a lot of problems. And some of the examples my surgeons used to tell me, or doctors used to tell me, I am too busy, especially the people in the emergency department. I'm too busy to tell me to go and wash my hands after every patient. I mean, yes, I know you're busy, but guys, there's infection going around. So we got to think about it. So for operating theater challenges, you see hand hygiene as well. Contaminated surgical instruments. How many times surgeons get back their instrument with a piece of bone stuck in the middle of the forceps or the scissors, or a residue that sticks on the side of the scissors or the knife or the instruments or the retractors or even the suction cannulas. There were residues stuck in there when we were using it for surgery, and they call that, sterilized and clean instruments. And we still find that there is inadequacy in terms of how we clean those instruments itself. And one of those big causes are from there. Improper surgical site preparation. In many environments where surgery, a busy surgery room, we tend to prep our patients. We always say we prep our patients. Sometimes we don't prep them enough. Sometimes we just prep them in an inadequate manner, if I may. Because there are still cases where there were a lot of the solutions, the cleaning solutions, the skin prep solutions that are under the patient's back during surgery, because they were just watering the patient on the top, and it all got pulled up in the operating table. When they use a diatomy pencil and start cutting, they create burns because they were a pool of water. Electricity transmit to water, and there were burns cases that happens as well. But it wasn't the burn cases that I'm talking about. It's more about how do we actually prep our patients? Did we just soak them with water on top, or do we really prep them properly? Right? And we see a lot of those examples. So improper surgical site preparation is still a concern. And this is, this practice is something we do every time, every procedure. But still, there is inadequacy in that context. The last piece is ventilation. And you can see here, we have surfaces, we have cleaning surfaces, then air. Proper ventilation of the operating room is essential. A lot of times I question the maintenance. We always prepare the room clean. And we talk about the room being very clean. The number of air exchange, the kind of filters that we use, the room environment, did we actually clean the room? It's very important. So ventilation becomes one of the key concerns. I think now after COVID, everybody is even more concerned about ventilations in the room because of what you call air transmittable disease, and we now recognize that it becomes an important area. So pay attention to your air within that, because a lot of study shows or report shows that there is issues with ventilation itself. What are other practices that we find concerning? Overcrowding and congestion. I appreciate some of the universities, especially or teaching hospitals, some surgeons love to invite peers to join him in the operating room. And that's fantastic. But I always say this, operating room is not a barbecue pit. We are not here to have a party. If we have too many people, you are purely introducing risk of contamination in your operating theater. So we cannot have too many people inside the operating theater, number one. Number two, you cannot have your circulating staff or your allied health running in and out the room all the time when the door is open and closed during the procedure itself. So these are things that I think we must, small things, but we must take consideration and we need to be aware of, right? Inadequate staff training, I guess this is something that we all recognize. People say training is not enough. Sometimes I think training is adequate. It's just the compliance to the training that is provided to the staff is important. The coaching provided to the staff is important. The adequacy of that needs to be looked at in our practices. Many of the report has suggested that people who actually in that environment is lack of the IPC protocols that is in there. So training is one of the issue. Inadequate post-operative care, proper wound care after surgery is essential. I think this is something that is given. When I first got the data and analyze it and we put this together, I'm like, why is people still talking about proper wound care after surgery is essential? Obviously, we need to have a good wound care setup or program. right kind of dressings, the right amount of dressings for our patients before we move them out of PACU. I am surprised when I first saw the numbers and also the information that we still have problem post-operatively with wound care. I'm just very surprised actually, because I would thought that wound care today is already very well established, post-surgical wound care. I don't see any inadequacy in that unless we in areas where we really don't have good dressing materials, then we have those challenges. But in a lot of our healthcare facility today, some of all these dressings that is needed is available. This point, I don't personally don't quite agree, but it's in the report when I read most of it, and a lot of the stats says that lack of antibiotic prophylaxis. I don't quite agree to this. I know I'm not a clinician by training, but I know some of my clinician buddies and friends were all telling me there are lists of protocols for type of surgeries where we do antibiotic as a prophylaxis for pre-surgery, and those are primarily for very long surgeries, I was told. But again, antibiotic is used because we think, and especially pre-surgery, right? Because we think the patient is going to get infected. So if we think the patient is going to get infected, the risk is about, long surgery. And the other risk is about the environment that you're doing the surgery itself. So we are telling ourselves that we can't even trust our own environment. That's why we need to use an antibiotic as a prophylaxis so that we can ensure that we don't have any infection post-surgery itself. So this is again some of those points that were highlighted. Inadequate surveillance and reporting. This is a global issue. There is a lot of cases that are not reported, and because it's not reported, we don't learn about it. We don't learn about it. We couldn't share with the community. We couldn't learn what to do best, what not to do best. So the surveillance as to how much infection really is happening in the operating room, or from the operating or from surgery, is still unknown. Some of the statistics we have, but I think it's larger than that in terms of the numbers. But we still don't have everything in paper yet. So lack of reporting does not really help us in looking at the data itself, or the lessons itself more. Some of the established multi-facade approach to deal with the risks of infection in the operating theater: patient prep before surgery, protocol guidelines, compliance, infection control measures with technology. So think about using technology, process engineering protocols. This is going to be a topic from ACRI and also many that we will be talking about. We are looking at what we call a total system safety, and engineering protocols is one of those most effective way of helping us prevent surgical site infection. And we'll be looking at that in more detail as well. Your environmental and facility, I think Dr. Sachin is going to talk more about it. Again, continuous monitoring and risk assessment. We will never, if we believe that we will never be able to eradicate the problem that we have today, right now, then you got to continue monitoring it and continue to assess yourself in your practices, to continue to look for the risks and those gaps within our processes so that we can continue to address them. Some examples of potential hazards, and like I mentioned, time of surgery, the longer you are having that surgery, patient are exposed, the higher the chances. Surgical gloves. It's a big issue. And many of surgeons are not changing their glove frequent enough, especially for long surgeries. Another study, I didn't have the data here, but I remember reading it. Somebody did a test, they wear a double glove and they put it into an environment that is similar to operating theater. They leave that glove there open in the air. 5 hours later, the entire glove was contaminated. without touching any blood. There was no blood residue. There was nothing. It was just a clean paragraph. They put it on a mannequin. They put it in an environment that is mimicking the operating theater environment. 5 hours later, the entire glove is contaminated. They actually swap it and they actually learn about it. So, ladies and gentlemen, your sterile glove can get contaminated. It's an area of germ colonization. So, and especially when you're touching areas like blood, liquids and all that. So your gloves is not entirely clean all the time. So changing your glove during surgery, especially long surgery, is something that you want to think about. So glove is a big issue. The type of glove you use is also a big issue. So think about on that part as well. Circulating nurse and allied staff in OT, I mentioned that again. We don't want too many of them in one room. Adequate is enough. And then we do not like that they open the door, close the door, open the door, close the door, as if this is like a walking hall where people will walk in and out. There is a reason why we have a double door or an ante room before we get into the OT. But we still want to make sure that the doors are closed. Instrument use for debridement needs to be clean. And I say clean means it has to be really clean and sterilized because we see a lot of cross-contamination from there. Give you a good example. Study shown many years ago that those who knows adenoidectomy, we are to remove the adenoid tissue from your throat. There's a surgery done by ENT. We used to use the stainless steel kind of instruments. We sterilize them and we use it for the next patient and all that. I remember in the UK, there was they banned the use of metal instrument for that procedure because mad cow disease wouldn't die under the 132-degree sterilization. So there were still residues of the mad cow disease. So they have a disease that transmit from patient A to B to C to D. So some of those things that we think we have cleaned it still exist. So it depends on the kind of disease we have. Some of the examples of things that, and this couple of slides are good reminders for you to really think about so that you still carry on what we're supposed to do adequately. So where are the germs? Clinical surfaces, human skin, medical equipment. So these are areas where we see that germs resides. What are some basic standard precautions that we all take? Clean common areas daily, disinfect clean surface daily, sterile medical equipment. So all this, I don't think I need to read this, but I just want to emphasize on how it is clean. So a lot of times we say we clean, but we actually need to rub or scrub the surface when we clean. So the training provided to the people who clean is extremely important because a lot of times we use our hand and softly wipe and that's done. So sometimes it's not that we don't clean enough. So technique of cleaning needs to be re-emphasized. Managing the spread of germs, who hosts the germ? So we look at a place, now we look at who? The patient, the healthcare workers, and your visitors. So some of the things that are recommended to proceed: isolate potential infectious patient, which is what you're doing now. Ensures tissues and no-touch waste receptacles are available in common area. This is not very well practiced because it's not very much available in common area. I've walked through many of the hospitals. You got to think about it. What do you mean by that common area? And how do you have them ready in those areas that is needed? For example, you have more closer to the areas where you have the isolated patients or patients that are identified to be potentially infectious. You may want to have more of those, right? Recommended appropriate vaccination for all staff, provide accessibility to hand washing facility. See, these are still basic things that we talk about, hand sanitization. I think we still need to do this every other day. I have a colleague who is an expert in hand infection. So she is going to write a chapter soon in WHO for WHO as well. And she tells me everything, and you think hand washing is so easy, but there's still a lot of issues that we see. Provides visual aid and universal precaution on infection control. I think this is very good to educate both your patients and your visitors, as well as to remind our healthcare workers that we still are working in a dangerous environment. We have to make sure that we take precaution itself. What are some of the modes of transmission that we have identified, right? Contact with humans, contact with surface, inhalation, and ingestions. These are how germs travels, right? So some of the precautions that you want to take note of is properly dispose of contaminated waste. Again, it relates to the bin that we talk about. And then demonstrate, reinforce proper hand hygiene on an ongoing training and observation. I like the word training, but in our risk management world, training as a strategy to infection prevention is not the most effective one. We need to couple it with some process engineering most of the time. Use the adequate PPEs, ensure consistent availability, offer masks to coughing patients and visitors, provide air ventilation and filtration system in areas where you need them. These are some of the examples of what I call checklists on areas where we think people should be doing. And this is one of those checklists we required of our cleaning colleagues who actually disinfect the areas where we want them to disinfect. And we want to make sure that the checklist is completed so that they have actually done the work. And a lot of times, based on experience, I know even though we have the checklist, like I said, the technique and the commitment to do that disinfection, that work of cleaning is actually very, very important. So there's a difference between taking a cloth and softly wipe them on the surface and rubbing it on the surface. So there is a difference to that. Some other disinfection recommendation, make sure that you do this for patient, residents, and also the staff. Make sure we identify rooms with aerosol generating procedures. Make sure there's adequate ventilation or filtration system for those aerosol generating procedure rooms. Ensure that, of course, COVID patient areas are being disinfected. The right kind of disinfection are used. Training for the staff, like I said, is oftentimes required. Use checklists to help you ensure that those work has been done. Again, I said the technique of doing those work are more important as well. Checklist is good, but looking at the people doing it is more important. Using a junk disinfection technologies. So what are some of those examples of a junk technologies? During COVID, I see a lot of new innovative technologies. People use this to mist on people. They created a tunnel where people have to walk through a spray mist of things, of disinfectant, and thinking with that, people who walk through are clean. And then they come up with all sorts of disinfectant for commercial use. Not sure if it's good enough, but we see a lot of those. One of those that are very good and has proven to have some effectiveness is actually the UV robot that people are talking about. And I'll talk more about that. UV robot alone is not good enough. It is an adjunct technology. It's used in combination of your regular cleaning work. You cannot just use a UV robot and think that everything is good. That's for sure. Airflow, how do we control and how do we use technology to control the airflow? Very, very important. And these are some of those things that people are sort of utilizing, especially the UV robots and the airflow control after COVID. And these are some of the experience we see from some of the hospitals today as well. Now, with that, I hope I've given you an overview. It's not all in-depth, an overview, and a lot of the recommendations based on the studies that has been done are something that you are aware of. But I want to re-emphasize that although you are aware of it, I think the way we are carrying out and implementing is very important. Please take note of that. And with that, thank you very much. I end my presentation.
Thank you, Eric, for this wonderful, very useful presentation. First of all, I wanted to answer multiple questions in our chat. Yes, we will share the slides with all the guests of our webinar, so don't worry about that. And it might be a good idea to print out certain things from Eric's presentation. For example, the checklist that can be used, or some reminders about where germs live and what surfaces require specific attention. So generally, as Eric said, we asked our speakers to give an overview of the general requirements and global best practices. We do understand that our scheduled time, 1.5 hours, is not enough to provide you with all the specific details of infection control in the operating theater. But our target today was actually to highlight specific misinterpretations and some maybe facts, as Eric said, which are a revelation, so that you step back a little bit and maybe you are inspired to go back to your operating theater and review your practices and review your facility, your infrastructure, and the methods you are using, so that maybe you will be able to change certain things, and maybe we can recommend you what specifically to focus on. Also, it's important, the idea that Eric had in his presentation is that, yes, there are multiple elements. The layout plays significant role, and we will be talking about it in a couple of minutes. Of course, use of protective equipment is also very important. So basically, there are obvious things that everyone, every medical worker basically knows from the institute. That's that the instruments should be sterilized, that staff should change their clothes, there should be PPE. However, in real life, we see that there are little things that matter, exactly as Eric said. For example, how you put on the surgical gloves. And based on our practice, unfortunately, we see that not all staff follow the rules and follow the requirements. There are specific ways to put on surgical gloves. What you do after you put on surgical gloves, because sometimes we see that staff start touching everything with their surgical gloves, although there is certain recommendations that how you hold your hands after putting on surgical gloves. Even such little things like surgical boots, what you wear inside the operating theater, there are recommendations for them as well. For example, they always should be light color, because then you can see when they are contaminated. And of course, you're not supposed to change them when you go in. However, we see lots of staff in multiple countries doing this, of course, thus compromising the cleanliness of the operating theater. This very important, and as Eric said, the area which is supposed to be the cleanest in the hospital. So lots of things to consider, and I hope our presentation does inspire you to review the processes that you are using and to have a fresh look. So as I already said, layout plays specific role. So I'm happy to introduce our second speaker. It's Dr. Sachin Wag, an expert in hospital code construction. And Dr. Sachin will be talking about the best practices in the layout of the operating theater and how it is related to infection control issues. Dr. Sachin, you're welcome.
Thank you, Yulia, and thanks to the IFC team for coordinating this webinar. A warm hello to everyone across the globe. Thanks to Eric for his lucid talk and setting up the stage for me. There is going to be a little bit of overlap, but it's definitely intentional. So I am Dr. Sachin Wag, medical planner and hospital design consultant. We work in Asia and Africa. I've been associated with World Bank Group IFC for the past 5 years, and this is my third webinar. Earlier, we did one on the CSSD and one on infrastructure for quality. I'm also a NABH and NQAS assessor, which are the national accreditation systems for in the country. And I've tried to collate a few experiences of those surveys that we have done for various hospitals, and I hope it benefits you all. I've also been a visiting faculty, and one of the takeaway is that over the years, the profile of students also keeps on changing. The current generation is quite sharp, and especially the millennials and the Gen Z. So what I try to do is put the onus on them to identify what is the problem. So when we are doing this operation theater class, I ask them a hypothetical question. We say that I want to do a surgery in this classroom. How can we do it? So they say it's a little difficult. We need a lot of equipment and a lot of appliances. I said, okay, I'll give you the operation theater lights, the table, the anesthesia machine, the life support systems, medical gases. Now can you do a surgery? And then after dwelling for some time, then the answer comes, but this area is relatively not clean. There's quite a bit of dust over here. I said, so what happens? But the patient will get infected. I said, we all are sitting in this classroom. We are not getting infected, Then the answer comes, we are breaching the skin barrier of the patient. We are taking an incision. We are going deep inside the body. We are exposing the vital organs. And that is a big problem, because the skin by default is the most natural barrier for infections. So what we are doing here, so that stage, that creates the stage for, the importance of, avoiding infection in the operation theater, which brings us to the environmental triad that we have learned in the public health classes, that for any infection, we have an agent, we have a host, and the environment is very important. The host is definitely the patient. The agent is going to be the microorganism. So all that we are left with to control is the environment. And as Donna Bedian has proposed in his model for quality assessment, it is a structure which then gets inculcated into the process, which then leads to the outcome. So all that we talk about quality, initiates with the structure. If your structure is not going to be proper, we are going to have problem, which is what brings us to the layout of the operating room. So infrastructure is part of these issues. It is the hardware that is essential. It is an enabler and not an obstacle. When we talk about all the requirements of OT, the management and promoters feel that these are too many requirements, but this is what we are trying to highlight, is that it is going to be an enabler. And Eric has also pointed out that it will save you a lot of inpatient days to increase the turnover of surgical patients. By and large, yes, and definitely surgery, the patient wouldn't have had this infection if he hadn't had that surgery, So it is definitely an opportunistic infection. So even morally, we are responsible for that. It's a nosocomial hospital acquired infection. So it, as we have the popular dictum, premium non nocere, first do no harm. So we have no right, on this planet to, do that intervention, which will actually lead to some more pain for the patient. And the biggest thing is that this is all preventable. And how preventable? We'll just run through that. So the best part is to create the aseptic environment. And how do we do that? Like Eric said, applicable transmissions are droplets, contact, fomites. Contact, again, not only the hand touch, but also the skin. The skin sheds a lot of cells, and hair also. We'll touch this point in a subsequent slide. And also fomites, is your instruments, like what we spoke about, sterile instruments. And last but not the least, it is also about staff safety. The staff is dealing with so much of body fluid of the patient, like we say in universal precaution, any fluid is assumed to be infectious. So staff safety also has to be at the same time very important. How do we address these applicable transmissions? Sterile instruments, definitely, to take care of that. Disinfect surfaces and strict hygiene, for which we need to get into the surgical attire. We cannot enter into your street clothes and our street footwear. Okay. And also be very diligent regarding what things we touch and where we have a contact. And also a big associated thing is the air management. When we talk about contact and fomites, we address that. But what about the droplets? And what about the ambient air, which is consisting of lot of dust particles that we spoke in the initial this thing. So how to manage that is basically the filtration and the pressure system that we will discuss in the subsequent slides. So first we'll talk about the OT complex layout design, okay, and then dwell a little bit more onto the interior material finishes and definitely the air conditioning part. Yeah. So when we talk about layout design, essentially operation theaters have a 3-zone system. Okay, even the facility guidelines recommend unrestricted, semi-restricted, and restricted area. And we have broken down into, say, a zone which is totally outside, not concerned with the operating room, which is the entrance lobby, or you could have the public waiting in the offices. And then there is a transient zone between the outside and the middle zone, which cannot be forgotten, where your actual trolley change, your counseling room happens. You have the staff change rooms and toilets. Okay, there's a lot of rinsing of instruments that happens here. On the other hand, you have the consumable stores, which has access from the medical supplies and also the pantry area. Okay, if you wish to have one. And then after change, then the people go into the middle zone, which is relatively clean zone. Okay, this is where you would have your pre-op and post-op hold areas along with your nurse station and the OT control. Okay, here is where you would have your medicines, especially the anesthetic medications, the nurse in charge, anesthetist room, also the doctor's lounges. The linen and clean stores. And then the final area is the inner zone where you have the sterile corridor. And the sterile corridor does not have any other thing except for the scrub stations and the operating room. Anything addition you could have is the sterile stores, which is again your instruments, maybe a flash sterilizer and an equipment bay. Okay. Now, how these are related with the attire? Say from the second last line, if you could refer, you could have the people would come in the straight shoes and footwear, and here is where the footwear change would happen, and the people would don on into the surgical attire. Okay, this is where they would roam around in the middle zone, and there is no restriction for that transfer. But once they would want to enter the inner zone, wearing of the mask will be essential here. Okay, so besides your other, address components, the mask would be essential in the inner zone. And how this would translate for the ventilation, for the air conditioning, is that the air pressure, we have a very differential air pressure across the zones. So you would have a very high pressure zone, relatively high pressure zone in the operating rooms. Okay, then a relatively positive again in the sterile corridor, a little bit less in the middle zone, and a negative pressure, okay, in the outer areas. Okay, so the purpose of doing this is that the operating rooms will be supplied with filtered air, okay, and it will be on pressure so that there will be no contamination that can come from the other direction. So this way we will be able to achieve unidirectional flow of air. Okay. There's also one more section which quite a few people have, which is having a separate disposal area, but that's a different topic to be discussed. We can address it subsequently if you have time. Okay. This I'll show you another layer. I'll show you a layout so that you can correlate these areas properly. We have quite a few hospital layout designs. This is one of the latest that we did. So here you would have an outer zone which is totally unrelated to the OT, but here we have the trolley change area, which is the interstitial space. You would also have the staff change rooms. So I have a male staff, you have a female staff and doctor change. You have the change cubicles with the clean linen. Okay. You also have the toilets here in. Okay. And the cubicles to don in and the clean footwear. After doing those changes, then you can come in the middle zone. Okay. Here you also have access to the counseling room and the OT substore window. In the middle zone, then you have the staff lounges, you have the pre-op and the post-op, okay, with their nurse controls and the anesthetic room, the nurse in charge, and the offices. After this, then you have one more barrier, which is the final barrier that goes into the inner zone, where you have the sterile stores and the operating rooms and the scrub stores, so scrub stations. So, like what we spoke in the air pressure, this is where you would have the maximum pressure of air, okay, which will be a little less in the inner zone, okay, and then little less in the middle zone. So air will always and always pass from the operating room to outside and from here to the middle zone, okay, and it will never cross from the opposite side. Here we were quite fortunate, Julia was asking me whether we could have a CSSD along with the operating room or should we have it separate, It totally depends on the layout of the hospital, how much floor space you have at your disposal. In this particular project, we were quite fortunate to have a wider floor plate. So we accommodated the central sterilization unit along with the operating room. So here you have the CSSD, okay, and with the wash disinfection area very proximally, the packing area in the center, and the sterile stores at the distal end, where you also have the supplies, one to the OT and second to the rest of the hospital. Okay. Here again, because the CSSD was very close, we have doubled up the change rooms. So even the CSSD staff can use the same change rooms. Once they are in the middle zone, they can use the ante room to enter the packing room. And from the packing through the ante room, again, go to the sterile store. In the same way, they can go back. This is how, again, the pressures in the CSSD would be maintained from very high sterile area to the clean area to the dirty area where you'd have negative pressure. Now, talking about some major pitfalls, or mistakes that people usually do, that we have encountered. Starting with the sizes of the OT, either they are too small or too large. And what is recommended usually for a general specialty OT is to have around 400 square feet, which is roughly 200 by 200 square feet. As the specialty increases, as you go into neurosurgery, cardiovascular surgeries, and robotic surgeries, the space could increase to 550 square feet. And image guiding would obviously need around 600 square feet, to accommodate the imaging components. Too large OTs are also not, good because they increase the surface area, and that surface area increase will also increase the, contact for opportunistic infection. Okay, so unnecessarily also we should not have too large OTs. Regarding the shape, we have seen different shapes, majorly rectangular shapes. But by and large, we should have squarish OTs, so that the length is equal to breadth. And the reason for that is the airflow, which I'll discuss in the next slide. And also, we should avoid too many projections. Like there are columns or there are ducts or there are shafts, and there are some adjoining walls. So that also we need to avoid. We need to maintain as uniform as possible, for the wall surfaces. And from the planning point of view, what we have seen is that people either have too few OTs or too many OTs. What I mean by too few is that, especially the earlier hospitals, which used to have a thumb rule of, say, 1:50 or 1:60 beds, they are facing a crunch of less operating rooms. That is because in the recent times, the average length of stay of patients after surgery has reduced drastically. Instead of, say, 7 to 8, 10 days, now patients can be discharged second or third day itself. The advances in technology also has aided this. And also a lot of specialties, they are doing daycare, like ophthalmology, you can send the patient the same day. There are a lot of daycare surgeries that have evolved. So that actually enhances the highlight on the operating room number. So your operating room number actually has to be based on your clinical program, okay, and the specialty mix that you have. Then again, coming to the location of the operating room, where the obvious thing is that we have to avoid high footfall areas. But again, depends on the shape of the building, whether it's a high-rise building or a low-rise building. Uh, it definitely has to be in a restricted area. But if you're talking about high-rise building, then essentially you would have the patient rooms on a tower. Say 6 story to ninth story or 10th story, and somewhere in the middle you would have the operating room, so that you have a service floor in the middle, so to service the operating rooms. But in the low-rise buildings, it is usually the floor below the terrace where you have the operating rooms. OT complex, like what we spoke in the layout earlier, I'll just go back to the earlier slide so that you relate to it. If you look at the orange area, okay, this area is roughly 1/4 of the total area of the operating room. So this entire area is a support area, which is what we have always seen is that people give two less support areas. What we recommend is that roughly the support area should be around, the total area of the OT complex should be roughly around 3.5 times of the OR area. That should be a justifiable space for that operating complex. The other pitfalls are, we just discussed the zoning, and the other pitfalls are all possible permutation and combinations of messing up with this zoning. A brief example is that, you have a change room and somewhere inside in the middle zone, you have a staff toilet. That's one of the, most prohibited thing. You also have a doctor's lounge in the middle zone and you have an attached toilet to that. The purpose of having a toilet with the change room is that, you should have a change, once you are visiting the toilet, because there's a lot of contamination that you would be carrying otherwise, which is not obviously visible, to naked eye. So that's one example. The other examples are, again, some people have pre-op areas before the middle zone. Some people have the post-operative as a 24-hour department. Like there was this hospital where they call it post-surgery department. After surgery, patient is wheeled into this post-op department, and since it is a 24-hour department, obviously the relatives are also going to visit this place. Okay, and this messes up the entire zoning. This defeats the purpose of zoning of the operating room. So if you are going to have a 24-hour department, okay, then you better have it outside the OT complex, or probably barricade it properly. Another problem is having the middle zone departments in the sterile corridor, which is like your endoscopy or even a labor room next to an operating room. These are an absolute no-no. Okay, we should have a barrier between this, because endoscopy primarily again will have negative pressure and is not allowed near the sterile areas. A very frequent thing we have seen is that we have an obstetric OR next to the labor room. Okay. Obviously, understanding that, in an obstructed labor, the expectant mother will be wheeled in immediately into the OR. But what people by and large forget is to give the change rooms for the doctors and the staff to change and then get into the sterile area. That's one of the frequent things that we have seen. And a lot of people actually miss out on the middle zone itself. So they have a change room which opens directly into the sterile corridor. We're not criticizing anyone, but we are just trying to highlight some issues of concern which should be addressed in a very constructive, positive way. Okay. Now, there are a few operational things which, though not related directly to the infrastructure, but a lot of people do pre-anesthesia checkup on the day of the surgery itself. Probably they are posting for the surgery on 9 o'clock. They'll call the patient at 7 o'clock or 7:30, and then have this pre-anesthesia checkup, just in the proximal area of the OT complex. The problem is that, the anesthetist will be roaming around between the sterile corridor, the middle zone, and the outer zone, in and out frequently. And that definitely is a matter of concern. The second elephant in the room is the refreshment eating area. The staff in the OT work for long hours. It is inhuman to deprive them of any refreshment or eating, which we obviously understand is required. But taking these into the middle zone and worst in the sterile areas is catastrophical. We should have, like what we displayed in the layout. You should have a secluded zone for refreshment, for a short bite and not a sumptuous meal. And then they can get back into the middle zone and then continue their work. Also, a few people have, few areas we have seen, after the surgery, the instrument wash is conducted in the scrub sink itself. Again, very bad. The scrub sink is a holier than thou area where all people will get washed up, to get into doing a surgery. So instrument wash is the last thing that should happen there. Uh, they have we have some options of doors, having conflicting views. In cases where, sliding doors, not only require the aperture for entry, which is your 5 feet width entry, but also equal and additional area for sliding it, on the wall. Now, due to design, a lot of times, there is a deficiency of space. So what a lot of vendors do is that they slide the door inside the operating room, like what you see in this adjoining picture. This is inside the OT and the OT door is sliding inside. The only problem is that even if though it is having a console cap, there are a lot of joints in this. The OT door is having a motor of itself, which requires a lot of grease also. Okay. And lot of channels and components, which definitely have to be outside the OT. They have to be avoided inside the OT. So that's one thing we would like to highlight. Also, a lot of people use floor-mounted spring doors. This is to swing the door both inside and outside the OT. Okay. Nowadays you have ceiling suspended doors which can be used for this purpose, because floor-mounted doors actually have a big cavity in the floor, and if you open that steel cap, you'll find lot of dirt in that. It will be filled with junk. So that is again one area where contamination should be avoided. Coming to the interiors, okay, we have to avoid horizontal surfaces as much as possible. Okay. There's one instance when our principal assessor, okay, with the bare hand, okay, just rubbed over a surface on the cupboard inside the OT. And the hand was filled with all lint. Okay, apparently this is because of settling of all the particles. Horizontal surfaces, definitely because of gravity, they will gather dust, and if left unattended, okay, it will definitely be create more nuisance for the staff. Also, we have to avoid as much as possible the floor mounted equipment. Okay, so primarily all your equipment will be either ceiling suspended, like the OT lights or pendants, or on casters like your OT table and maybe the trolleys, so that when required, you could actually clean the entire floor, whenever required. So that's again a something favorable thing that we can have. And we have to choose the interiors very diligently. It should be effectively cleanable. It should be disinfectant compatible. That it shouldn't have the betadine stains and things like that. It should be maintainable, durable to overcome the strain and the scratches. It should be scratch proof. And also replaceable. In case something gets damaged, you want to replace it, it should be replaceable immediately or maybe at a very shorter time. Okay. We definitely need a conductive and anti-static flooring so that the table does not catch, electrical charge, which requires copper stripping on the floor. And also the color should not be disturbing. A bare stainless steel OTs, they emit lot of glare. Okay, even colors like yellow or green, may disturb the perception of the surgeon. Okay, so we have to avoid that, and also avoid soft stones like marble, which gets eroded over time. It's quite porous. Okay, and the floor leveling should be appropriate during the construction time. Okay. Other pitfalls that we have seen, this used to be a norm a few decades ago. Now it's reduced a lot, is having two tables in one operating room. We still see this in a few hospitals. It's absolute no-no. Okay, one OT should have only one table. I'll not exaggerate this too much, but it's a dictum. Okay. Uh, we spoke about the obstetric thing. Having toilets above the OT is again inviting trouble. Okay, a toilet above the OT, so we have to be very careful what we have on top of the OT on the upper floor. Because in case of leakages, again, not only the water drippage, which is dirty water, we will also have fungal growth and also potential bacterial growth. Poor waterproofing in case the OR is just below the terrace in what we spoke about location. Lockers, in one case we saw the lockers were planned outside the change room, which is practically impossible. Also important is the footwear change, especially in tropical climates like in India, where the footwear has to be changed. Okay, from the street footwear to the OT footwear, or you'd want to probably use the shoe covers. And also the surgical attire misuse, which Eric also tried to highlight, and also Julia was concerned about, was people wearing the OT clothes and roaming around the hospital, like what we spoke in the anesthetist coming out of the. So it is definitely not visible to the naked eye, but once you're in the OT, once you are standing below the laminar airflow of the OT, there is a lot of particles that are being shed, and we have no right, to contaminate our own linen and then get into the sterile corridor. So that we have to be very, very strict about, though directly not related to the infrastructure, but definitely on an operational level has to be addressed. Which brings us to, I'll shortly cover this. Okay, I won't take much of your time. Is the air conditioning, which is the heart of doing the operating room. What we spoke about, triple plus, double plus, and then single plus. Air conditioning definitely required for temperature maintenance, air pressure, again the relative humidity, okay, which we acquire, and again the air changes per hour. There are per air changes to, because again dilution, as we say, is the best form of purification. So the operation theater requires dedicated AHUs, which are air handling units, okay, which have triple stage filtration. Okay, so not only the support areas, we have to find an appropriate location for the AHUs also. The blue thing that you see is the supply of air, purified air into the OT, and here you would have your terminal HEPA filters, which is 0.3 micron filter. Okay, and here from here is the air is thrown onto the table. So in the second section, you'll see the laminar airflow coming onto the table. So this is the cleanest air that we have. And on the four corners, you'll see the return air ducts, the red things that you see in this 3D. So these return air ducts will take the same air back to the AHUs, okay, where it will be again filtered, added with some fresh air, and then again repumped into the operating room. So for maintaining of this cycle, you have to have this laminar airflow. And many a times we see that the space for AHU is missing. Okay. That is a big concern, because at times we have seen AHUs next to maybe areas like pathology, okay, or maybe some isolation rooms, or maybe even toilet ducts. Okay, so that's definitely no. At times, people are not able to get all the four corners for return air ducts. So in that scenario, what we could have is, rather than three, it's better to have two return air ducts, and that too diagonally opposite, so that we try to maintain the laminar airflow as much as possible. Laminar airflow, as they say, lamina is the layer. So we create a barrier for the patient's surgical site. Also, one more thing we can do is we can have filters at the return air ducts. So a lot of people forget this. No, we should have filters at the return air ducts, so the lot of lint is arrested here itself, rather than taking it to the AHUs. Many people have window ACs, absolutely contraindicated. Many people have split ACs. And this is the worst, because split ACs have no element of fresh air. It is the same air which is cooled and again thrown back into the room. So the volume of air that you had in the morning, it is the same volume of air that you will have by the end of the day. So imagine the amount of contamination that you will be having in the room built up over the hours. Okay. So in split AC, absolute no. 1 AHU per OR is what we recommend. Okay. Though it is not contraindicated to have 1 AHU for more than 1 OR. But rather, why we recommend is because it is more challenging, to supply to multiple ORs. Also, it will be great to have, if the AHU is on the upper floor, it will be great to have the cutout for the inlet outside the OT room. Okay, a lot of people have the cutouts directly on the OT, which is not a good practice. It should be outside the OT, and then the duct should be brought inside the operating room. And one more thing we could do is, insulate the ceiling slab, okay, because the ceiling also sheds a lot of particles. Okay, that is one point. The second point is because there is so much cold air in the operating room, it will also lead to sweating. Okay, once this, and then that again leads to dripping. So by and large, we've tried to cover major aspects of layout design, and I leave it to you. If you have any questions, we are welcome for the questions. We'll answer them. That's my time, Julia.
Thank you. Thank you very much, Dr. Sachin. Also very interesting facts. Lots of revelation, I think, and also lots of things that change the usual perception of the layout of the operating theater, of the infrastructure of the operating theater. And here I also wanted to make a point that, of course, certain things are very detailed, certain things are relate to engineering. We do not think that you're going to be rebuilding your operating theater tomorrow. What we were thinking about, we thought that certain things might be inspiring for you, which relate to maybe changing moving one service from one existing room to another service, which would allow better flow of the process. Also, we were thinking that you could save this presentation, and we will share the slides, by the way, and the recording is saved on our web page, and also it is saved on YouTube. So when your hospital decides to refurbish the operating theater, to rebuild or build a new one, extend the facility, then you can revisit this and also get some ideas. And also we wanted to let you know about all the key elements, how many elements relate to the infrastructure, and that infrastructure helps to simplify the process and thus save the effort and make the processes more straightforward, more streamlined for your staff. So when you are thinking about refurbishment, when you are thinking about building a new layout, new operating theater, please think about investing effort into it and making it as convenient as possible, because it saves a lot of effort in infection control, relating to infection control. That's the message we wanted to convey today to you. And once again, we get a lot of requests regarding the sharing the slides. Yes, we will share the slides. Don't worry about that. And now I wanted to talk a little bit about our infection control module, because it's a big event for us. This module is open for public now, and I kindly ask my colleague Natalia to share just 3 slides. It will be very brief introduction. So just a few words for those of you who already joined our webinars. You know that we have our online learning campus, so basically online training modules that we developed. Some of them relate to international patient safety goals, some of them relate partially to infection control. It was our COVID response isolation module. And now we are happy to introduce the prevention and control of infection in other facilities. So basically how to design for infection control. So the module is self-paced. It means that you don't need to do it from the beginning till the end in one go. You basically can start and stop and then continue up. Well, it's absolutely free. You don't pay. So it's very useful and both for quality and also if you want to educate some quality champions in prevention. Also, we ask them to have a model and then give a certificate in their profile, in their records. So basically, how to implement PCI program, how to develop a plan, how to conduct the education training. So lots of specifics there in this module. And you might need to register. That's the only effort that is required in the on the website so that you get access to it. It might take a little bit of time, but it's worth it, definitely. So you should be stopped by it. But again, I repeat, no fee. So we will share the link in our chat now. And this is how it can go to the next slide, please. So that you can recognize, so I get some messages and the voice breaking, so I will move closer to the microphone. So this is how the first page looks. So this is introduction to prevention and control of infection. I hope my voice is better now. And then we look at the content. We look at the next slide, please. So the content here you can see, so it has lots of chapters, and then it also has lots of practical tools in it, certain documents that you can print out and start using in your facility. Also, you can disseminate them as staff, etc., etc. So hope you will like it. And we will, once again, we will share in the chat how you can access this module. So now we are moving to our Q&A session, and also I wanted to say that today we're getting lots of guests, lots of members in the audience, and we get lots of questions. So due to the time limitations, I don't think we are already, by the way, we already know that it's going to take a little bit longer today, so we will have additional like 10-15 minutes to address most critical, most important questions, but definitely we will not be able to address all of them. So we wanted to invite you to our community practice. Please join if you haven't yet done so. The link was in the chat some time ago, but maybe my colleague can share it once again. Because we got so many specific, very important questions on infection control in the operating theater, we will ask our experts to reply in writing, and we will publish them in our community of practice. So you will definitely get all the tips and tricks and all the right answers if you join. So basically, one of the questions that arrived first is basically again relates to infrastructure. So most likely it's for Dr. Sachin. Can operating theater be located in the basement? This is also a very common practice, especially for converted facilities that we see operating theater in the basement. Is it a good practice, and what specific infection control challenges arise in this situation?
Sure. Thank you. Basically speaking, basement is not prohibited per se, okay, maybe from infection control point of view, because by and large, the basements then actually become the biggest ventilated spaces, because ventilation is the primary concern in a basement. And since OT complex is highly ventilated, it obviously is not a question, but first and foremost, it should not be restricted by law of the land, okay? A lot of places have prohibition on having habitat spaces in basements. And the second biggest concern is regarding the fire protection. Okay, since it is a contained space, it is actually calling for catastrophe. Unless and until you have proper exits, okay, the best is the ramp. Okay, to lead you to outside, because again, because there are a lot of critical equipment that are used in the operating room, sprinklers are avoided in the OT complex. Okay, so that actually handicaps you. So by and large, if these 2, 3 things are taken care of, okay, it will be then to the management to how to utilize the space.
Thanks so much, Dr. Sachin. Actually, we are receiving lots of questions on specific how-tos, and also specifically regarding the processes that Eric or you described, like, for instance, changing the clothes while leaving the operating theater and entering the operating theater. So one of the questions is it okay to wear the outdoor clothes, but just put a gown on top of it without major changing, major reshuffle of clothes? Is it okay? Is it acceptable, or no, as you, Dr. Sachin, say?
Correct. Which is why we spoke about the basic principle, of the contamination that is going to lead to your infection. Okay, so as long as you are taking care of that, okay, because the linen is the outermost surface, which is going to avoid any shedding of skin particles, or even the cap when we talk about, any hair fall, accidental hair fall or something like that. Till the time it is covered up, it's fair enough. Okay.
Okay.
We can use gown for occasional visitors, but if the staff is going to work for a longer time, it's better to get into the surgical attire.
Okay. Thanks a lot. So now the question, I think, to both of our experts, again, based on your experience, the check of quality of air. Is air sampling still relevant, or should be a particle count done, or what's the global best practice now? What's the most recent trend?
Could you come again, Yulia?
Yes. So what are the best practices to check the quality of air these days?
Yeah, so air sampling is the best thing, and then they take swab cultures also periodically.
Okay, so both actually they complement each other. Okay,
yes.
that sounds great. Yeah, and now a question which relates to what Eric mentioned. So what would be the best practice and the solution to stop transmitting infections by the use of multiple displays and the computers? Because Eric was absolutely right, mentioning, like, for example, lots of hospitals these days use safe surgery checklist on the iPads. So they, on the one hand, they make the practice safer. On the other hand, they constantly hand over the iPad to each other. So by solving one problem, they create another problem. So what would be the solution in this case?
There is no stopping the use of computers, iPads, mobile phones today in our operating room. So if you're thinking to find, processes and techniques to stop them from using, that's futile, because a lot of technology are coming into our hospital. You will see more computers in your operating theater. So the only way to do it is cleaning it. And that is why in my presentation, I've emphasized the technique of cleaning. So we do a lot of trainings to the people. So now you got to take care of the people who is actually cleaning or disinfecting your facility, your equipments and stuff in the OT itself. So they play a very important role now, because some of them will just take a cloth and just simply wipe and spray and then simply wipe. That's not going to do it. And if you read the instruction of the disinfectant and how it has to be used, the technique that it has to do, you got to thoroughly follow that instruction of cleaning, because cleaning the surface is more than just spray some disinfectant and let it sit there and thinking that it will kill everything on the screen itself. That's a misconception. You got to scrub it. So you got to rub it on the area and the surface that you need to clean. So with more computers and laptops and iPads and mobile phones in the operating room, it only means one thing: you got to do more cleaning. So when you're planning for your operating theater, you've got to emphasize that a lot more. There isn't a way to stop it, unfortunately.
Thanks, Eric. So next question actually is a combination of several questions, because basically we receive questions like, okay, so there are these requirements. Is it a must, and is it one size fits all, or there are adaptations? Like, for example, all these requirements, do they apply for shorter procedures as well? Like, for instance, ophthalmology procedures. Some of them are very, very short. So is it all the same rules? Or regarding the layout, so this layout, is it for every single country, or are there any specifics depending on like the climate, because ventilation might change, and there are different also how to say, different historical trends regarding the layout and looks of the operating theater in different parts of the world. So how applicable and adaptable should these requirements be, considering we have audience from all around the world?
Yeah, so the purpose of this presentation is to highlight the essence of maintaining a sterile aseptic environment. Okay, we spoke about staff change, we spoke about movement of staff, we spoke about instruments, we spoke about how the air pressure is maintained and the purification and filtration. So by and large, these are the principles. Your layout could change basically depending on whether you have a central corridor. Okay, like there are 2-3 models for operating rooms. One, you could have a racetrack model where you have a dirty corridor, okay, separate, connected to the operating rooms. You could have one where you have everything coming and going through the same route, okay, where you have the sterile instruments, the staff and patients, materials and equipment, as well as the dirty, which definitely is enclosed in a plastic, bag. And then there is also a concept of peripheral corridors, where the staff, patient, material and dirty comes from one side, and the sterile instruments and the tray setup comes from the other side. Okay, so these are a few options that one could have. By and large, as long as you're committed to the principle, okay, you could adopt any of these models. Coming to the minor procedures, definitely they could be in the middle zone. Okay, like if they are very short acting anesthesia, or it's a very superficial cut, or things like that, or a short sedation, then they could definitely be in the middle. Like you actually have minor OTs in maybe the trauma emergency, or even in the outpatient department. So that you could have in a middle zone.
Okay, thank you, Dr. Sachin. So Eric, anything from you on this? Any advice that you based on your experience?
Well, I agree with Dr. Sachin in terms of the facility, and that is why in some many countries actually, the operating theater are defined in a different kind of operating theater. Some of them has different air cleanliness within the facility. It's purposely built that way. Some procedures are very dirty, so they would have a different kind of filtration. Some surgeries like neurosurgery and cardiac surgery for the brain and for the heart, you want to have extreme cleanliness in that room, so air filtration is a separate thing to talk about. But in a nutshell, for minor surgeries, yes, we can do it in a not 100% clean, but again, instruments that are used, even for eye, for example, I stress again, the cleanliness of those instruments, your hand, the specialist hand, and the scrub nurses that is supporting, the wearing of gown, that cannot be discounted. There is no tier of saying that there is a cheaper gown or a thinner gown, or I do not have to wear a mask in that minor procedure. There is no such protocol for that, because you're still going to do an open procedure. Anything that is intervention, we still need to keep to the standard of cleanliness that we need, especially when we are providing that care in that context. So I will still stick to the rules of and the protocols of cleanliness that we need for individuals when we're performing those procedures itself in the OT. Yeah.
Thank you. Thank you very much, Eric. So basically, if it's a shorter procedure, it's no excuse to relax in anything that relates to infection control. That's a great point. Thanks. Thanks a lot. Before we move to the last question, because we are running out of time, really, and thanks a lot for the majority of our audience for staying with us longer. We really, really appreciate it. Before we move to the last question, two organizational issues. So issue number one relates to the certificates. After the end of this webinar, all our guests will receive a survey on exit form, and please mention your name the way you want it to be seen on the certificate and your email there. So when you fill in all the required fields, then it gives us an opportunity to send you a certificate. This is a very important point. Another important point, in case you missed, so the certificates will be by the 15th of May. So don't worry if it doesn't arrive today or tomorrow. It's fine, because we have some internal procedures, and also we have over 500 participants. So it might take some time, and it's absolutely normal. Don't worry about that. The second organizational issue is actually that I wanted to tell you about the next webinar that we are having. So the topic will be protection for staff. From the point of view of infection control. And actually, we wanted to ask you to think, maybe you want to be also a speaker, an expert, to share your experience of building staff protection program for the next webinar, which we plan to have beginning of June. Most likely it will be June 16th, but 6th, sorry, but it might change. So if you are interested in participating, please reach out to us. You can send an email and say that you are interested, and then we can discuss it with you. Now the last question. So the last question actually is, what is septic operating theater? And also a relevant question, very important one, separation of clean and dirty surgeries. Which is the best practice? How to organize it? Should there be a dedicated clean surgery operating theater, or it can be mixed? What's the rule of mixing it? And also, which is the best way to locate emergency operating theater? Because basically, it's kind of always more dirty, could be potentially more dirty than others because it's emergency and we don't know yet. So let's maybe discuss this question. It's quite a big one, but it's going to be the last one.
I take this. Yeah. Once we are talking about septic infectious, we have to realize that there are two types of infections. Okay, one is that there is a infected appendix or ruptured appendix, or maybe the GI tract or something like that, or maybe even the lungs or some other organs in the body, which is at the site of the infection. The second type of infection is airborne infection. Okay. Here, why we are trying to classify is because airborne infection, let's assume that you have a patient who has to go a normal operation, but is having tuberculosis. Okay. So the disease is not infectious, but the patient has tuberculosis, which is again can contaminate the environment and also affect the staff. So by and large, these both are addressed in the septic OT, which is relatively kept in the middle zone. Okay, or in the layout that we spoke about, but with an anteroom. Point number one, and second, it has to have 100% exhaust, so that there is no air coming out of the operating room. Okay. To answer your third point, yes, definitely emergency ORs are also perceived to be infectious because obviously there will be contaminated wounds and things like that. Again, the patient is wheeled in directly without any preparation. So again, so the same rules would apply there also, is that you would have an anteroom, and then you would have 100% exhaust for the air that is ventilated in the OT. That exhausted air also needs to be filtered because we can't just release it into the environment. So there has to be a filtered exhaust for this. Okay, but by and large, the support areas will definitely be there. There will definitely be a change room for the staff and the middle zone and then the OT.
Thank you. Thank you very much, Dr. Sachin. So if Eric has nothing to say on this, I'm afraid we're really running out of time. So thanks a lot for staying longer with us. And also I wanted to thank all our speakers today for this wonderful session, for sharing lots of practical tips and tricks and advice. Hope it was a little bit changing the perception of our audience so that they can have a fresh look at the practices and the infrastructure that they have in the operating theater. Once again, certain questions that we received, we didn't have physically time to address, but please join our community of practice and we will share it. We will share the answers of our experts in there. And also, please fill in, do not forget to fill in the survey on exit. So that's all from me. Thank you very much for joining. Hope to see you during our next webinar. We will send an invitation separately.
Julia,
those who would like to participate.
Julia,
yes, you're welcome. Yulia, yes, and Natasha, anything from you?
Yeah, I think we can share our event on Epic as well.
Okay, yes, please.
Yeah, can you say that we're gonna have Epic webinar soon?
Yes, so as you know, we have ethical principles on healthcare, and we have a webinar and also an upcoming workshop. So we will be sharing the information by email, so don't miss it, and please join.
And Julia, one more important announcement. If you wrote your email and your name in the chat, they will not be saved. So we saw a lot of emails and names there. Now, this is not the place that you put it. When you click on leave the webinar, you will be taken to the survey on exit. And the survey on exit is the right place to put your name and your email for the certificate. So please, if you put it in the chat, it is not working. So please put it in the survey on exit, and it appears when you click the leave button, which I am about to do as our webinar is ending. Thanks.